Okay, today we'll be talking to you about hypothyroidism, a clinical approach. We'll be seeing hypothyroid patients day in and day out, so you know many of the things actually. But this will be an attempt to approach in a different way to see you uh, as a postgraduate, of, diagnosing rare kind of cases and to treat rationally. So, to give you some background, like thyroid hormone secretion is secreted from the, thyroid trophic hormone is released from the hypothalamus and which stimulates the pituitary, which secretes thyroid stimulating hormone, and in turn it secretes, stimulates the thyroid gland and T4 and T3. There's thyroxine secreted, and majority of them are T4, and then T4 is converted to T3 peripherally. Now we got a feedback control loop, which means the secretion is very much controlled by a system called feedback control system. If the T4 is high in the blood than the required level physiologically, it in turns, you know, has a negative control on the pituitary as well as at the hypothalamic level. So the TRH secretion is stopped, are reduced, TSH is reduced, and eventually T3 and T4 secretion is reduced. And once if it goes below the target level, then again the TRS is secreted through the usual mechanisms. And what does it do? The thyroxine has got physiological effects, a variety of effects, of which the first one is the basal metabolic rate is controlled by thyroxine. It increases the basal metabolic rate. It depends on the metabolic status. It can induce lipolysis or lipid synthesis. That means a catabolic hormone. It can also stimulate the metabolism of carbohydrates. But when it comes to the proteins, it's an anabolic effect. Thyroid hormones can induce the catabolism of proteins in high doses, but it is a permissive effect on catecholamines. That's why, when in a hyperadrenergic state, the thyroxine will enhance the effect of catecholamines, of which we'll talk about that a little bit later. That's why we need to be careful in patients with coronary artery disease. In children, thyroid hormones act synergistically with growth hormone to stimulate bone growth. So it is involved in the growth, and the impact of thyroid hormone in CNS, this neurological systems, are very important during the prenatal period. It is needed for the maturation of the brain. In adults, it can affect the mood. Hyperthyroidism can lead to hyperexcitability and irritability. You all know that. So, hypothyroidism can cause impaired memory, slowed speech, and sleepiness as well. It has got a profound effect on the central nervous system of the individual who have low thyroxine, as well as when it comes to the mother, it can affect the fetus. So thyroid level is very important for fetal neural maturity as well as neural functions. Thyroid hormone also affects the fertility, ovulation, menstruation. So, usually it will be the routine test, thyroid function test, which is called for workup of infertility, ovulation, menstrual irregularities. So, how do you approach clinical case that comes to you? So, obviously, history comes first. The people classically comes with hoarseness of voice, weight gain, lethargy, hair fall, menstrual irregularities, etc. These are common presentation. Sometimes they may say that there is a swelling in the neck as well as there is pain in the neck. So this pain increase in size and swelling over the thyroid. And when you examine, just carefully note for skin erythema, tenderness of the thyroid gland or the swelling in front of the neck in altered curvature from the cricoid to the sternal arch. So also you can approach from the front of the patient to examine, or you can go behind the patient and put your hands to the front and just fix the thyroid, fix the trachea, and then you can just feel the two fingers on both sides. So, and also carefully see if the mass, if you find, is in the central or at the sides. And there can be swelling of the thyroid with the involved the isthmus, and sometimes there can be thyroid problem above the level of higher this thyroglossal cyst, which can be seen very easily when you ask the patient to put out the tongue and thyroglossal cyst moves. Some rarely you can have a lingual thyroid, there may not be any thyroid in the neck in the children. So it's always good to look at inspect the oral cavity and palpate the mass from the front, sides, and back. Any lymphadenopathy, and sometimes if you may need to do indirect laryngoscopy, calling in the ENT colleagues to see the movement of the vocal cord. Suppose because of the thyroid gland, which is affected by the malignancy, directly affecting the neck, or sometimes there can be infiltration into the recurrent laryngeal nerve. So obviously you have to examine the patient carefully after going through the history. And the hypothyroid, see this is the spectrum. So this is neonatal congenital hypothyroidism. If you see this one, and short stature in the say, early childhood and late childhood, and when they grow into adult, you can see a puffiness of the face, eyelids, and thick lips, and even it can affect the elderly. So it's a classical feature, and you obviously uh, check for the pulse to look for bradycardia, and also you do hang up reflex by doing a deep tendon reflex. See, there is a slow relaxation. There can be a contraction, then there will be slow relaxation. This is a hung up reflex. So the clinical sign you can elicit. And now coming to the clinical, very clinical aspect, there's a presentation. How do they present? And so far we've been talking about classical presentations. Now, atypical presentations. Patient may come with fatigue, lethargy, can come with just a constipation, cold intolerance, muscle cramps. Many times the muscle cramps, especially at the night, can be a sign of hypothyroidism. And menorrhagia, any abnormal uterine bleeding. And if they add more weight, they'll have carpal tunnels, there's tingling and numbness at the hands, and the regular outlet, sometimes it goes. So there may not be obvious sensory loss over the palm or any wasting or weakness. It can be tingling and numbness below the wrist. Slowness of intellectual and motor functions. And suddenly it's not performing well in the school or college or in the regular profession. So the weight gain, of course, look for the dry skin. Sometimes the dermatologist may be worried if they look about they're looking at ichthyosis, dry skin, hair loss, and the host why subject to sleep apnea. So one thing, the subject to sleep apnea is one of the commonest condition next to obesity in hypothyroidism. And sometimes there can be frank myxedema coma, though it's rare, but we do see that. And it can present as hyponatremia, isolated hyponatremia as a feature of myxedema coma. So, having gone through that, you don't stop with making a diagnosis of hypothyroidism clinically. And you'll have to look at the cause, the etiology of the hypothyroidism. There is goitrous or non-goitrous or secondary. And if you look at the goitrous, the common one is autoimmune thyroiditis, that's Hashimotos. Sometimes thyroid, subacute thyroiditis, it's painful thyroiditis. Postpartum thyroiditis is painless, which occur after the delivery, especially if the patient they have some antibodies and present classically after the delivery, after 3 or 4 months. and iodine deficiency, one of the commonest ones. So the non-goiters, the patient, there may not be any neck swelling and no goiter, and it can be following a surgical removal or thyroidectomy or radioactive iodine ablation, following a radiation for head and neck malignancies, following chemotherapy, and it can be congenital and sometimes diagnosed very late, even the congenital hypothyroidism. Atrophic thyroiditis. These are all non-guiders. Just to clinically differentiate what it could be, you just divide carefully between variety of differentials. So, secondary, which is very rare, but again, you need to think about it when you have atypical thyroid function test. Transient hypothyroidism, which usually in a newborn, and it gets corrected after some time. So the lab investigations normally you start with TSH alone will tell you the functional status of the patient. But if you do T4 and TSH, that's good enough. And if hyperthyroidism is suspected, you can go for free T3, free T4 TSH. Sorry. Uh, if goiter or nodules, ask for ultrasound. And thyroid antibodies, if there is diffuse thyromegaly and not for nodular variety. And fine needle aspiration cytology, if the nodules, if you find an ultrasound is more than 1 centimeters, or if they have multiple nodules on the dominant one to rule malignancy. And nuclear thyroid scan, if the cause is uncertain, if you find a diffuse goiter and hyperthyroidism, and you do not know whether it is a Graves' disease or it is a subacute thyroiditis with the presentation of hyperthyroidism. Or you just do it routinely before planning for radioactive iodine ablation. A thyroid scan can be done using technetium 99, which is a quick one, and it's also it's better in pregnancy the patient who is pregnant with a goiter evaluation, and you don't do radioactive iodine study in pregnancy. Yeah. Check the thyroid uptake and the volume and prepare and plan about radioactive iodine ablation. These are all the tests that you need to think about in select situations. So, when thyroid interpreting thyroid function test is not easy always. Suppose if you get a situation, the free T4 is normal, TSH is normal, it's euthyroid, very straightforward. Thyroxine is normal, pituitary secreting TSH is also normal. So if you the T3, T4 is low and TSH is high, obviously hypothyroidism. And if you look at T3, T4 is high and TSH is low, it's hyperthyroidism. Obviously, free T4 is high and TSH is low. But what if the free T4 is normal, but TSH is alone suppressed? Can be high, subclinical hyper, but again remember, sometimes it can be recent treatment with hyperthyroidism. Following a treatment with hyperthyroidism with antithyroid drugs, free T4 comes back to normal, but TSH takes some more time to settle down because of the pituitary suppression. It may take 3 or 4 months before, even if your dosage is adequate. And sometimes it can be an effect of steroids, dopamine, non-thyroidal illness. And free T4 is normal, TSH is high. Again, it is subclinical hypo, but it can be poor compliance. The patient may not be taking tablets. So some days they take, some days they don't, and they don't cover every day. So there can be poor compliance with the levothyroxine therapy, and sometimes a recovery phase of non-thyroid illness and TSH resistance, which are rare situations. Again, you have to think about it as a postgraduate or as a physician, you know. And again, if you see that free T4 is low and TSH is normal or low, both are low. So perhaps you'll have to think that you repeat the test and see if the TSH is low or normal and FT4 is low, the central hypothyroidism. There can be an assay problem. You'll have to repeat that, and there can be normal thyroid, so, non-thyroid illness. So, again, if you condition, there can be you may come across with both are high. The free T4 is high, TSH is not suppressed. So what is that? So again, thyroid hormone resistance. That's called the peripheral resistance. Because the TSH secretes and free T4 is high, but again tissue is not responding, peripheral tissues. So then you have high TSH. So keep in mind, now we'll just move on to the clinical cases. That's the main aspect of this presentation. So far I've just given you overview of the physiology, function, the action of thyroid hormone, and how to other representations, possible presentations, clinical examination, lab, etc. Now we just jump into case discussions. Case number one, you see 40-year-old women with diffuse goiter, firm to feel with no lymphadenopathy, comes to you, and then you do an ultrasound, confirms diffuse thyromegaly, which is not nodule. There are no nodules. The antibody titers are high. There's antimicrosomal antibody, there's anti-TPO antibodies, another name for it, and anti-thyroglobulin antibodies. And the functional status is hypothyroid. This T4 is low and TSH is high. And what is your diagnosis? It's Hashimotos, straight, or just iodine deficiency, or hormonal dysgenesis. So all the three are possible. But the hormone of which the hormonal dysgenesis is very less likely because it's a congenital defect of the enzymes handling the thyroid uh, hormone synthesis, and you do perchlorate test and just confirm it. So maybe there are two different types of possibles. And what is Hashimotos, which is the commonest thyroid disorder? There's autoimmune disorder affecting mainly females. Antibodies are positive, and diffuse thyromegaly presents as euthyroid sometimes. Many times they bring the daughter for evaluation is simple goiter. So it's just diffuse enlargement, a grade 1 goiter. And you check the thyroid function test is normal clinically and biochemically. And then sometimes they may be hypothyroid. So obviously treatment is T4 replacement. And one important point that some and having diagnosed Hashimoto's, that's the commonest one with the diffuse goiter and hypothyroidism. Don't stop with that. And sometimes they come out and say, goiter seems to be little more prominent. That's one thing the TSH has gone up because of poor compliance or because the requirement of thyroxine may be high. Sometimes if there is a rapid swelling in it, so be careful. There can be lymphoma just coming out on the background of Hashimoto's. So do an FNAC if there is a rapid rise. Not routinely for any diffuse goiter with hypothyroid picture. You can make a diagnosis. You don't need FNAC for Hashimoto's, proving Hashimoto's. Antibodies are enough. But if there is a rapid rise of goiter, you have to do FNAC. Iodine deficiency can cause hypothyroidism, yes, and usually it should be prevalent across the community, so it's not a very random patient. So you can say that the patient, the family, the community may have many children with a iodine deficiency. So especially in the mountain areas, but it's very unlikely to see iodine deficiency in the around the plain areas and especially near the coastal region because the iodine is deficient when the water comes from the mountains. But then it picks up the iodine as it comes down and from the soil it picks up the iodine and then the iodine gets concentration is sufficient and you don't need iodine salt in the coastal areas. So I mean, yes, if you suspect, you may check urinary iodine level. That's a test which may give you the diagnosis. This hormonogenesis in a much younger age with a very huge goiter, with the chemical hypothyroidism, you have to diagnose. So Now that's a simple case. Now just see the next one. The 33-year-old female was investigated for obesity. So usually that's the one. So every obese children, the family wants to do thyroid function test. They know it's very popular, the idea. And also the general physician would like to do to rule out thyroid function test to rule hypothyroidism. But the TFT showed normal T3, normal T4, but little raised TSH 8.61. Yeah, they may be excited to see that the TSH 8.651 is abnormal. We have found discovered hypothyroidism, which may be the reason for obesity. But it's not the case always. I'll tell you why. So, will you repeat the test? This is abnormal, or will you treat with the levothyroxine? So, you do the repeat the test. It comes again with the same kind of values. That only isolated TSH increase. We know that when isolated TSH is increased, it's subclinical hypothyroidism. So, what's the rationale of handling the patient or treating the patient? You have to treat with replacement of levothyroxine if TSH is more than 10 international units. That's a generalized agreement across all associations, including American Thyroid Society or Indian Thyroid Association, and so. But if you what do you do? If the less than 5 is normal, between 5 and 10. So if the TSH is less than 10 and more than 5, and check if the antibody titers. So if the antibodies, which anti-TP was increased, or if the patient has got hypothyroid symptoms, tiredness, lethargy, and so on. And if the patient is pregnant or infertile, yes, you should treat. Because eventually, pregnancy is a condition where thyroxine requirement will go up, and you have to treat that immediately. And in infertile couple, there is, it's better to keep less than 7 TSH. So, suppose if the patient comes with a hypercholesterolemia, yes, it's a vascular risk factor, and that hypothyroidism can cause dyslipidemia, this increased cholesterol. So, you may have to treat. Right. Otherwise, you don't treat subclinical hypothyroidism. So, case number three, a 45-year-old male admitted in ICU for some other reason. That's for ventilator support for COPD. And he developed transient AF, atrial fibrillation, and on heparin as a prophylaxis for of stroke. Uh, the indication of atrial fibrillation, heparin is not. And meanwhile, the patient looked like hypothyroid, clinical suspicion was there and TFT was requested. And you see, free T4 is high and free T3 is low, but TSH is low. There seems to be a little confusion here. So T4 is high, TSH is low, agreeable, but what happens to free T3 is low, T4 is high. You repeat that, the test comes as the same. There's no surprise. So, do you think the patient has got hyperthyroidism? Because he can easily connect hyperthyroidism with the atrial fibrillation the patient has got. And you jump, you are excited to say that yes, this is the reason for atrial fibrillation. I'm going to treat hyperthyroidism, and A is going to go. Because treating atrial fibrillation is very important from the stroke prevention point of view, and you have to do electrocution, 50 joules or 7500, and you want to revert the rhythm immediately. But you cannot do so with hyperthyroidism because the rhythm will reappear unless you treat hyperthyroidism. This is the question many times we come across. And there is a term called non-thyroidal illness. Earlier, the term was different. What does it mean? So, that means in severe stress, uh, especially when the patient comes to ICU, we find abnormal TFT. That's due to suppression of pituitary and lack of conversion of free T4 to T3. That's why the T4 was high in this particular patient, T3 was low. And because of the pituitary suppression, it's an adaptation. Pituitary suppression is a necessity in an emergency, and we'll talk about that during the pituitary session. So we please note that the low TSH, low T3 with variable T4 is always possible. This is a condition called non-thyroid illness. And again, and the use of heparin may interfere with the T4 assay. So that's one aspect of it. So ICU, stress, pituitary suppression, you have an abnormal TFT, don't ignore, you don't jump to any conclusion to make a diagnosis. You have to do it a little bit later. Right. So during the recovery again in non-thyroid illness, it's a little bit difficult to comprehend. So patient should be evaluated after 3 months. So physician refers a lady into 3 months of pregnancy with history of abortion in the past, and her TFT shows that's total T4 and total T3 are and normal TSH, sorry, and high total T4, high total T3, and normal TSH with positive antibody titer. She wants your view on how to proceed, and you can explain easily that T3, T4 total fraction may be high in normal pregnancy. I'll just talk about that later in other cases. But it can be quite normal. Yes, the TSH can be normal. And the antibodies are positive. She wants your view on how to proceed. The antibodies, sometimes they refer to you during the infertility workup. The antibodies are positive. Thyroid function tests are quite normal, but they want to know the significance of it. And the issue is whether she has any thyroid dysfunction at all or significance. What is the significance of the antibody? The anti-TPO, anti-thyroglobulin antibodies tells you that there is an autoimmune basis for the condition, and sometimes the preclinical patient might not have established subclinical hypothyroidism or hypothyroidism, and biochemically thyroid function test may be number one, only antibodies may be positive. But usually they may progress to become hypothyroid. So it was earlier believed that low dose T4 thyroxine 20 micrograms may improve fertility, but it was disproved later. There's no routine use of this just because you found an antibody. So you don't have to do antibodies routinely unless in borderline cases of TSH. So you can reassure the patient. Again, ANC mother is 2 months amenorrhea was referred with TFT report of T3, T4 is high, and TSH is low. Yeah, it looks like hyperthyroidism, right? Anyway, she is just recovering from vomiting. Obviously, in the first trimester, there can be increased vomiting, sometimes hyperemesis. She is a known case of hypothyroidism on 100 micrograms of levothyroxine. Yes, so is she taking too much of thyroxine? Do you want to reduce the dose of levothyroxine? That's a question posed by the gynecologist. So, Ops wants to know if there is a need for dose reduction. It's not a common clinical scenario. Just you will see in and out every day when you become after you start your practice. So, hormonal changes in pregnancy. Look at that. There is a huge changes happening in all the pituitary, thyroid, gonads, and everywhere. The entire body system changes because every system changes, like cardiovascular, respiratory, is also the endocrine system. So what happens in first trimester? This HCG is high. Second trimester, progesterone is high, and then the estrogen starts rising. Progesterone starts rising during the seventh, and this comes down the trimester. And remember that just see one more. This ACG is high, and see the thyroid, the ACG it can stimulate the thyroid gland because it's got a homology, the structural similarity between TSH and HCG, and so thereby it can secrete more T4 and also suppress the TSH. And also hyperestrogenism can increase thyroid binding globulin that can, and again thereby there is increased total hormones. So these are all the things. So there is an increased estrogen by 2 to 4, and HCG and TSH. Uh, he- yeah, HCG and TSH is similar structure, so it can stimulate thyroid gland, and there is a peripheral metabolism. There's a decreased alteration from uh, from T4 to T3. So there's some changes. There is also increased thyroid hormone binding level. This can affect thyroid function test. But the patient HCG goes up and there is a lot of chaos happening because of pregnancy. And so the thyroid function is altered because of the pregnancy. But the patient is normal with thyroid. So go by trimester specific T4 and TSH. TSH is suppressed in the first trimester. T4 is high, which is normal. But if the patient comes to you with a normal thyroid function test, if she happens to be already on levothyroxine, add immediately 20% extra dose of levothyroxine, even though T3, T4, TSH are normal because the requirement is high. In pregnancy, you have to add 25% of the original dose. Suppose if they take 100, put it on 125 before asking for thyroid function test. And then to monitor TSH on weekly basis. If there is an alteration, if it's fine, do it every month for the first half of the pregnancy. Again, the first 3 months are critical for the fetal brain maturity and neural maturity. So we have to put them on absolutely normal thyroid level in the mother. So after 20 weeks or so, the fetal thyroid gets mature and it can produce its own thyroxine. And try to target between 2.5 to 4 in pregnancy, in first, second, and third trimester. And but you should absolutely treat if it's more than 4 to 10. There's a norm here. Sometimes it keeps changing, and we'll have to see the current trend at that point of time. If the antibody is positive, you have to treat between 4 and 10. About 10 anyway, we're going to treat. And 2.5 to 4 gray area, but initially we were treating until last year. So you have to follow the specific guidelines from time to time. So this is another, suddenly they come out without, they're asymptomatic, they have some abnormal TFT, they is referred. There's a 35-year-old woman with a seizure disorder undergoes brain MRI and it's noted to have partial empty cell. There is something, the pituitary test is normal except for a serum TSH 0.4. So you thought probably because of the hypopituitarism you have TSH, but you see the other axis is normal, gonadal axis, cortisol axis, adrenal axis are normal. So current medication, patient is on carbamazine and lisinopril. The issue is whether the patient got second hypothyroidism because the pituitary is abnormal, because the empty cell you but say that the patient is on anti-epileptic and this can alter the thyroid function test. All the variety of anti-TB drugs and lithium and again dopamine agonist in ICU and in cardiology patient with amiodarone all can affect the TSH levels. So don't interpret very easily. Case number 7, 64-year-old woman with hyperlipidemia has unstable angina. She is waiting for cardiac cath, which shows done, which shows three vessel disease, and scheduled for bypass surgery. The serum TS is 52, so probably it was missed. The diagnosis was not done earlier, and the free T4 is quite little lowish, but okay. But the TS is obviously high. Would you like to the surgeon wants to know you want to treat the hypothyroidism, make the TSH normal, you take for surgery because it carries a risk in surgery because already the patient is serious danger. She may die at any time. So, what will be your advice as a physician? In an emergency, you don't wait for hypothyroidism to be fully corrected. You can proceed with surgery. Simultaneously, you can start treating with the high dose of thyroxine. But if the patient is Cardiac patient, start with low dose because the patient may throw arrhythmias. Because as I said, it can enhance cardiac catecholamine action, and any sympathetic activity will increase the heart rate, and the patient may go in for immediate infarction. So, even though the TSH is high in the cardiac setting, you have to start with the low dose, and you cannot correct TSH very easily. It may take time, but before that, the patient has to go for surgery. Anesthetist will take little risk. Of course, hypothyroidism may not behave badly in surgery, but unlike hyperthyroidism, may do very badly. Okay, case number 8, 66-year-old women diagnosed to have hypothyroidism 10 years ago with history of irregular treatment, consults you for exertional chest pain and ECG is abnormal. Yeah, kind of similar kind of patient which is anemic, and TSH is more than 150 now, and you have to treat the patient, but also anemic. Apart from anti-angial, you want to start our thyroxine and iron. What would you start? How will you start the treatment? Yes, in a young adult with no comorbidities, start with 1.5 microgram per kilogram. Suppose if you weigh 60, yeah, 100 micrograms is sufficient. That's a normal routine dose. But start with 25 microgram, not milligram, microgram, and increase by 12.5 microgram every 4 weeks towards the target of TSH 4 to 5 in the elderly and CAD patients. So it may take time. So start very small dose, not 100 micrograms. And remember, iodine and calcium interferes with T4 absorption. So in pregnancy or in other anemia, other situations, you have to prescribe iron at the night time or at least 4 hours after the thyroxine dose. Otherwise, it will interfere with the thyroxine action. And again, case number 9. 70-year-old woman living alone was brought to an emergency with confusional state. On exam, she was hypothermic, bradycardia, and in shock. Thyroxine content was noted near the bed during time. So she lives alone. Probably she's hypothyroid patient. She's not been treated for some time. So because of memory impairment and so on. So lab shows hyponatremia, CT brain normal, blood sugar 138, RF. Your diagnosis, yeah, mixed edema coma. So patient is confused, hypothermic, bradycardic, and she's in metabolic acidosis, all kinds of sort cases. It's not CV. Of course, the cerebrovascular accident has to be ruled out. But any patient which is not fitting in with anything else, think about endocrine problem, especially hypothyroidism. And we have to do gradual rewarming, and patient is not conscious, they can't take orally. So you'll have to give the thyroxine via rectally. Levothyroxine can be given rectally. You can powder it and just give it to the right tube. And again, IV thyroxine is available in some countries, can be used. And there are controversies of use of oral T3 preparation, which is available in India even now. And sometimes they may think about giving T4 and T3 in very complex situations. It's not the context now. And case number 10, 28-year-old lady was referred to you by OGCN for hyperprolactinemia, not for hypothyroidism. During infertility workup, a married couple, the prolactin was little high. TMT tested 2 years ago was normal, but again, and now it was what next? Yes, I don't go too much into the hyperprolactinemia because this is not the day for discussing hyperprolactinemia. But remember that even if you find hyperthyroidism, you have to check for TSH, thyroid function test, because the thyroid hypothyroidism may cause hyperprolactinemia. And always rule out physiological cause of nipple stimulation or any dopamine intake, lesurate. So any hyperprolactinemia, borderline raise like 50, you have to think about these causes, and then always rule out hypothyroidism. So that's a connection between hyperprolactinemia and hypothyroidism. The last case, I think, a case of papillary CA underwent total thyroidectomy, radioactive iodine 1 year ago, was replaced with T4. What are how frequently you will do? So every time when patient returns to you after the thyroid surgery, thyroidectomy following, post thyroidectomy hypothyroidism, just examine the neck for swelling or node and thyroid function. Replace the LT4 with a target of zero point 0.1 to zero point 0.5, very strict. You cannot allow the patient to go for TSH of 2, 3 because it can stimulate paprikase and can return. So thyroglobulin again one more test we do in only during following follow-up of surgery. Okay, that means the TSH values are normal are different in post malignancy surgery. I think there's one more case. The last case, the 36-year-old lady comes for regular review for TSH report of 30 to 40, always 30 to 40. She says that I've been taking the medications regularly, doctor. So what happens to me? Why my TSH is not set? We commonly come across, even with the 300 micrograms or 400 micrograms of dose. So there are three possibilities: poor compliance, G absorption problem, or thyroxine resistance. If there is a persistent elevation, yes, poor drug compliance is the commonest one. They may forget, they may not like to take, and there's a first one. Second thing, it can be an absorption problem. So, if you want to confirm that the patient poor compliance, give 10 micrograms per kilogram. The maximum of levothyroxine 600 micrograms. Give orally under your custody and take hourly free T4 for next 5 hours. If there is an incremental rise of more than zero point 0.4 at the 3 hours value, that rules out malabsorption. If there is no increased rise because it is malabsorption, so you have to do malabsorption studies. So the carry-home message is atypical presentation of hypothyroidism has to be recognized, and TFT interpretation can be difficult sometimes, especially if the patient is taking medications or in ICU. Proper etiological diagnosis is also necessary, whether it is multinodular goiter or Hashimotos. So rule out hypothyroidism, hyperprolactinemia. Levothyroxine dose is individualized, not flat for everyone, not a common. So target TSH in reproductive women during infertility workup, keep always less than 4. In pregnancy, more than 4, less than 10. If the antibodies are positive, has to treat. And consider levothyroxine if between 2.5 to 4. Check TFT every 4 weeks for first half of the pregnancy, that is 5 months, and prenatal iron and calcium may impair LT4, especially given in different times. Following thyroidectomy and carcinoma, thyroid TSH should be kept less than zero point 0.1 to zero point 0.5. In patients with coronary artery disease and elderly, start with very low dose. And the TSH may settle down a little later. Don't worry about it. Don't push for normal TSH values as you do for the post-thyroidectomy for malignancy or in reproductive women or younger people. In pregnancy with hypothyroidism, add 20% additional dose of thyroxine at the time of diagnosis, even though the LT4 is normal, if the patient has been a hypothyroid patient becoming a mother. Right. So with that, I just finished, and I think learning is a joy. Keep learning. I hope you got a few points, and I'll be happy to answer your questions. Thank you.